We have our guest in the studio, and we also are welcoming our guests who are watching us now on KTN Home. From now until the top of the hour, our guest in the studio is Dr. Emmanuel Okunga. He is a medical epidemiologist. He is also the acting head in the Division of Disease Surveillance and Response at the Ministry of Health. The reason why Dr. Okunga is joining us today is because of a campaign that the government has been running in the last couple of weeks, and it's not the first time they're running this campaign. It's the polio vaccination campaign. You know, lately when you talk about vaccine, we've all been thinking about one vaccine. Which one? COVID. The other day I told you that I heard people moving around with loudspeakers, and they're talking about vaccine, chanjo. And I thought it was the COVID vaccine. And later is when it occurred to me, maybe it's actually the other vaccination campaign that's going on. Yeah? So, Dr. Okunga, karibu sana to the Situation Room.
Thank you very much.
It's good to have you, and we appreciate you having here. We call that the hot seat, but it's for our esteemed guests, such as yourself, who come to be with us on a day like today when we're celebrating a public holiday.
Thank you.
So, this polio vaccination campaign, when did it begin? When does it end? Let's start from there, and then you'll tell us why you decided to conduct this kind of campaign.
So thank you very much, Latif. This polio campaign, this particular round, began on Saturday, the 17th, and is intended to continue up to 21st, that is tomorrow. However, in counties where we have a large Muslim population, this will go on up to Thursday because of the holiday. Thank you.
Why are we doing a polio vaccination campaign?
So, largely, as you know, in Kenya, we had eliminated what we call the wild polio virus in the country in 2014. However, we remain in a region where a lot of countries are affected by civil strife, and therefore their immunization rates are very low. And because of the population movement between these countries, we continue to get imported cases of the polio virus into the country. So because we also have a disruption in our immunization services in the last 2 years due to the COVID pandemic, we have children that are at risk of transmission. About 300,000 children have missed their polio vaccination in the last 2 years. So, coupled with the detected cases of polio virus associated with children that came from Somalia, we are undertaking this vaccination campaign to protect the rest of the country.
How frequently do we have such campaigns? Is it an annual event? Is it something that only takes place when there's imminent danger lurking somewhere?
So the current campaigns are being undertaken in response to the detection of the virus circulation in Garissa and Mombasa. However, these are campaigns we've undertaken for more than 10 years now. These campaigns are meant to supplement usually the routine immunization. So when we think that immunization rates have gone down, and particularly for this round, because we have the new cases of virus in the country due to the importation, we are now doing what we call an outbreak response campaign. However, this does not stop the routine immunization which goes on in our clinics routinely.
So when you talk about these outbreak immunization campaigns, I think if I can say in the last 15 years or so, every so often I hear the government rolling out sort of an emergency immunization campaign that's nationwide. And I was even asking CT the other time, what does this reflect? Does it reflect a surveillance system that is working, or does it reflect a surveillance system that is not working?
Actually, this talks to a very effective surveillance system, because we do our surveillance in two ways. One, we look for all children that present with weakness in any of the limbs or multiple limbs, and that is what we call acute flaccid paralysis surveillance. But we also have surveillance sites that are based on our sewerage system, and we have about 17 sites in the country. So when we bring the two surveillance systems together, we are able to detect the virus in the country. So in this particular case, we detected the first circulation of the virus in December last year, and further circulation early in the year. And that is why we have to undertake this outbreak response.
You know, when we talk about an outbreak response, the question that comes to mind is, how widespread is the outbreak?
Yes. So for polio, a single case of virus detection is considered as an outbreak. And
One.
Why? Because for every case you detect out there are probably another 200,000 cases circulating in the community that may not be detected. So polio is a very highly infectious illness, and therefore we try to detect even one case to be able to show the transmission in cases. So for this particular outbreak, we think that this particular virus has been circulating for about the last 7-8 years in our neighboring country in Somalia. And this is what has led to the importation into Garissa and Mombasa.
You know, there's a generation of people, especially those in urban areas, whom you'll tell about polio and they cannot connect or even relate. And then there are those who have witnessed or experienced polio. So for the purpose of those that have never really understood what polio is, just tell us, what is this polio? How does it spread? And what are the symptoms? How does it manifest?
So thank you very much, Latif, again. So polio is a viral illness that manifests. Usually it will appear like a common flu. And then in a few days, if it is going to become symptomatic, you'll get weakness of the legs or the arms or both. On the extreme, you can have paralysis of the muscles of the chest, leading to you failing to breathe and subsequent death. So the majority of people that get polio infection do not show any symptoms. However, the ones that show paralysis, a number of them will get cured. However, and this is where our biggest challenge is, a number will have polio paralysis that is lifelong. And that is why you see a number of people walking with crutches. As they say, immunization is its own enemy, because when you succeed, people see fewer cases and then they forget that the illness existed. So in our current situation, we see fewer people with polio paralysis because of the success of the immunization program in this country. And that is why we have to remain vigilant all the time.
How does it spread?
So polio is spread through contaminated stool, stool contaminating water or food, and mainly it is spread within children because of their habits contaminating the soil around the homesteads and then playing in the same areas. Then that is transmitted through the hands and fingers to the mouth. That's what we call fecal-oral transmission.
Let me ask this question, Daktari. For the longest time, I have understood that polio vaccination is a normal undertaking that is provided for children.
Yes, that is true.
Yes.
City Muga.
Yes.
And we give polio vaccination at birth, after 4 weeks, another 4 weeks, and another 4 weeks. So we give polio vaccination routinely in our routine,
Yes.
in the immunization schedule.
So we are saying all the children who are born in this country are entitled and actually do receive that vaccination every single year or every time the children are born.
Yes, so it is a requirement for all the children born in this country, unless there is a very peculiar medical contraindication, to get polio vaccination at birth, after 4 weeks, another 4 weeks, and another 4 weeks. Now, this does not happen to all our children in this country for various reasons. There could be reasons around insecurity in certain areas. There are reasons about religious sects that do not believe in immunization. There could be reasons about just parents who do not want to be responsible enough to take care of their children's health. Of course, in other countries, a general breakdown in the health system means that you do not have vaccines available. So even if parents wanted to give their children vaccines, they would not have the vaccines available to them. So those are some of the reasons. And as I'd said before, in our country, usually our polio vaccination coverage is very high. However, in the last 2 years, because of the COVID challenges and people fearing to get to health facilities, we have about 300,000 children that have not been vaccinated. And that is the particular risk we have to protect our country from.
So if we say we have 300 children who have not been vaccinated, we are saying that these are children who are now at risk.
Yes.
That's one.
Yes.
But we're also saying, if I understand this correctly, is that should they then get infected, we then have an unfortunate situation where polio could actually spread at a rate that we may have difficulties containing.
That is exactly the position. And that is why we have to intervene very urgently. And this is something that is monitored all the way from WHO headquarters down to the country. However, the primary responsibility is for us as a country to prevent the same.
Has there ever been a time in this country when we had said, we are done with polio, because I remember the campaign to kick out polio. I remember that campaign very well. But was there a time when we sat back and said, something, we've got this under control and it's no longer an issue?
Actually, Kenya was declared polio-free in 2019. 2018, 2019. And so we do not, actually our last local polio transmission was in 2014. However, regions are declared polio-free as continents, largely. However, but individually, we as a country, we've been declared polio-free from 2019. So the risk to this country is from outside.
It's external.
Why do they do it continentally? Why is it in a continent? Why not just look at the country and its health situation?
Yeah, because the country is not divorced from its neighbors. So long as you have polio transmission anywhere near you, you remain at risk because of our population movements within the regions and even globally. That's why we also say that today only 2 countries in the world are endemic for polio. That is Pakistan and Afghanistan. And therefore the whole world remains at risk just because of those 2 countries. And that is why we have the polio eradication initiative that seeks to eradicate polio across the world. And until we have elimination of polio in Afghanistan and Pakistan, and a few other countries in the region who have a different mutant of the polio virus, we are not safe.
Just explain that a bit. You said 2 countries in the world that are endemic to polio, and this is Pakistan and Afghanistan. What does that mean?
So when we say endemic, it means that the disease transmission is continuous. The virus circulates within the country routinely, as opposed to a situation like ours where you get outbreaks, upsurges of cases sporadically. So in Pakistan and Afghanistan, because of the security challenges there, the routine immunization services are not up to date. So we have continuous transmission of the polio virus.
Dr. Help us with definitions here, okay? Endemic, I've got it, circulating within the country. Pandemic?
So pandemic is like now COVID, where we have cases, many cases of disease that are affecting many continents of the world.
That's a pandemic.
That's a pandemic.
An epidemic?
An epidemic can be a local outbreak affecting maybe a small geographical region. It can be a county, it can be a hotel. That is an outbreak.
So can you then say that this epidemic is a pandemic?
So yes, technically yes. When you have an epidemic that is affecting many continents, then it becomes a pandemic. Yes.
In the Situation Room with you this morning is Eric Latif, CT Muga, and our guest this hour, Dr. Emmanuel Okunga. He is the acting head, the Division of Disease Surveillance and Response of the Ministry of Health. This is the 3rd day, or is it the 4th? How do we count? From the 17th, 18th, 19th, 20th. 4th day, and the penultimate day of the nationwide polio vaccination campaign for the areas that have a large Muslim population. Is going to take place until the 22nd, and that's what we're discussing this morning with Dr. Okunga. So we know that countrywide, Doc, there is always the ongoing polio vaccination. Newborns, 4 weeks, go get the vaccine, the first jab. Then it said 4 weeks later, you get the second jab. 4 weeks after that, you get the third jab, right? So those that have gone through this and they're still, well, let's say within 3 months old, are they still going to get this vaccination during this campaign? Or who is exempted and who's supposed to get it?
So actually, this particular campaign is targeting all children in 13 counties that are considered at highest risk of the polio outbreak. And these are counties in northeastern province, Mandera, Garissa, Wajir. Then we have counties at the coast, Tana River. We have Mombasa, we have Lamu. We also have counties in eastern, Machakos, Kitui. We have Kajiado, then we have Nairobi, Kiambu. So in total, there are 13 counties that are considered to be at high risk. And all the children, irrespective of whether you've been vaccinated before, shall be vaccinated. And we do so because in additional vaccination just boosts your immune status. But missing out on the vaccination puts you at risk. So because we may not be able to identify every single child that may not have been vaccinated, we vaccinate all the children in the high-risk areas. So the other parts of the country are not being vaccinated, but it's based on the lower risk they are at. However, going forward, around October, November, we may have to expand the reach of vaccination because this is to fully protect ourselves, we have to do serial vaccination for that may have to cover the whole country and even the region, all the countries in the region, so that we can be able to control the outbreak. Because the outbreak is not just in Kenya, it is affecting countries like Somalia, Sudan, and many other countries on the continent.
Now, if we are taking this action in Kenya, are we then assuming that our neighbors or the areas that are also affected or have contributed to this situation that we are in are also taking similar action? And if they are not, how productive will our efforts be? Because here we are immunizing, we are making sure that we do our bit, but if the others aren't doing their bit, are we not going to be chasing our tails for quite some time to come?
That is true, CT, but as you know, you don't choose your neighbors. Huh? However, there is a continental effort to try and synchronize immunization campaigns in the region, and the campaign in October is meant to be synchronized in all the counties in the Horn of Africa region, and this is what will address your concerns. However, you know the situation in some of our neighboring countries is quite tricky because of the security challenges there. So there will always be immunization challenges, and therefore our risk will persist as long as there are health challenges in our neighboring countries.
How is our surveillance structured? You're the head of the Disease Surveillance and Response Division in MOH. How is it structured? How soon does information leave a health facility and come to your desk?
Yes, so we have a Department of Disease Surveillance and Epidemic Response in the Ministry of Health, under which lies a number of divisions that are responsible for monitoring all diseases in this country. And this division is then, this is at national level. At county level, we have 47 county disease surveillance coordinators. At the sub-county level, we have about 300 sub-county disease surveillance coordinators. And in each of our about 8,000 to 13,000 health facilities, we have surveillance focal persons. And then in the communities, we have community health volunteers who are supporting the surveillance function. And beyond that also, communities are able to report in our system. So on a routine day-to-day basis, we have a system of event-based surveillance where people are able to report into the system at any time, and that information will be captured within the surveillance system routinely. Then we also have weekly reporting into the system. We have monthly reporting and other reporting systems ad hoc. So we are able to detect disease outbreaks or disease upsurges or other events of public health concern almost instantaneously in this country.
There is something I'd like you to do for us. Just walk us through this. We are in a county. A county has a total number of 6 constituencies. Then they have wards. Okay. Then there are all these health facilities. Okay. What system do we use? For instance, people visit a health facility. Whatever brought them there is recorded. Okay. It is stored. Now, walk us through. How does all this information then move to the point where they get to, say, the county headquarters and then to the Ministry of Health?
Okay, thank you very much, Siti. So as I'd said, there are two systems. There's immediate reporting because the reporting is based on the urgency of the condition. So if we had a case of, say, polio,
Yes.
or a case of, say, Ebola, that is something that should be reported immediately, and within 24 hours we should have confirmed that situation or not. So that information will be recorded within our routine record system, but we'll also have a direct telephone communication to the head of the, in fact, to the Director General of Health within 24 hours. And the same report will have reached WHO within 24 to 48 hours, depending conditions we call public health emergencies of international concern. So that will be Ebola, things like COVID, other conditions that are likely to be transmitted across the world. So that will get immediate reports. However, there are other diseases that we monitor, like measles, like rubella, where we report on a weekly basis. And the records that are captured in our outpatient clinics are entered into our Ministry of Health information system called the DHIS, which then generates weekly reports. And on the basis of these weekly reports, we produce weekly bulletins within the ministry that then inform any response activities that need to be undertaken.
How do you diagnose polio?
So polio, as I said first, most children with polio will not have any symptoms. However, in a small proportion of the children who will develop paralysis, you begin by detecting that weakness in the limbs, sudden weakness in the limbs, either the lower limbs or the upper limbs, so the legs or the arms. And then you then take the stool samples from these children to the laboratory where the virus is looked for by different methods in the lab. So from the lab, that's when we get a definitive confirmation of polio.
And then now the information is passed on upwards. I'm asking this because my next question was going to be, how well trained are our healthcare workers at the local level in any of these 13,000 healthcare facilities across the country to detect a new disease? Let's say COVID was starting in the country. How is our surveillance system actually structured to be able to pick up there's something new that's happening in this area that we have never seen before?
Yes, so our health workers across the country, right from training, are trained to look out for unusual events. However, even within routine work conditions, we train our surveillance officers and other healthcare workers on our system we call integrated disease surveillance and response, which basically highlights diseases that are of importance within our regions. For example, in our country, we monitor 36 priority diseases. And we also look out for any other unusual events. So the surveillance officers are trained to look out for anything that is unusual. Similarly, the community health workers have also been trained to detect any unusual events of public health concern within the communities, which they report to the health system, and the surveillance officers go out to verify those concerns. So we think that our system is quite sensitive and we are able to detect most unusual events real time.
I want to ask a question about the community health workers. Now, I take it that the community health workers simply don't focus on polio as the only work that they do other work. Or
Yes.
do we have community health workers who are designated to specifically work in polio cases?
No.
Yes.
Community health workers actually do a variety of health interventions. And polio surveillance is just one of them.
My question is, Dr. Do we have enough? I know health is a devolved function, but from the days before it was devolved, have we ever had a situation where we actually have an adequate number of health workers to carry out these tasks that we require of them?
Yeah, of course, we cannot say we have adequate. Adequate is a very relative word, but in our situation, we cannot say we have adequate community health volunteers because it comes at a cost, both in training and sustaining of the operational facilitation for the teams. A number of our counties have taken up the challenge and have employed adequate numbers of community health volunteers, but we have challenges in a number of counties also, because you require a community health worker for almost every 50 people in this country. And therefore you can imagine the kind of workforce we are talking about, and to sustain them is also an operational issue. So it is work in progress.
But you see where I come from and where I'm coming from and where I'm trying to create the balance. One of the roles that community health workers, voluntary or otherwise, what they perform is they help us in not only the process of detecting and prevention are tied at the hips. So they play a very key role in preventing the proliferation of diseases and so forth. Now, yes, they come at a cost, but my understanding and from where I'm coming from is that a focus on the importance of the role or the work that they do has never been adequate. That's where the inadequacy is, understanding the importance of it. Because if you think back to the days when we had what we call extension workers, there were agricultural extension workers, health extension workers. By the way, this is a favorite topic of mine. I always bring it up. And when I have somebody of high standing like yourself, I will not let the opportunity go without my bringing it up yet again. Should the Ministry of Health not focus their attention on imparting this importance on the counties, that the health worker plays a far, far more important role than the role that we often attribute to those who now participate in the curative aspects of healthcare?
Thank you so much, CT. And if you've recognized over the past few years, the ministry has prioritized preventive healthcare as the route to universal healthcare. And this can be noted by the creation of the Department of Community Health Services in the ministry. When you also look at our universal health coverage strategy, primary healthcare is a key pillar of the same, and we cannot overemphasize that aspect. For us to get our health proper, we have to emphasize preventive healthcare, and this is where the community health workers play a very significant role. So, as you rightly say, the government is strongly involved in the rollout of community health services across the country. Of course, we also encourage our county governments to continue to invest in community health services as a way to improve our health services across the country. Because if you realize the burden of disease in this country, most people get sick or die of diseases that can actually be treated by even community health workers. Malaria, diarrhea, all this where the burden of our disease is. So once we sort that out, then we leave the routine health facilities to deal with the more chronic illnesses.
You know, it occurs to me that experts such as yourself and many others in the Ministry of Health and the entire chain of healthcare understand all these things. It's plain, like day and night. But then when it comes to implementation, where do the bottlenecks lie in terms of even resourcing and financing and managing? Is it on just understanding the role of the national versus county government? Is it a political issue? Where do the bottlenecks lie from where you stand as an expert?
I would not talk of bottlenecks as such, but this is really work in progress. So we cannot improve health services in one fell swoop. So there's progress, and if you look at our indicators over the last maybe 10, 20 years, we've reduced deaths of children by almost a third. We've reduced deaths of mothers by almost another third. And this is work in progress. So as you know, provision of these services also come at a cost. And so healthcare is quite resource intensive. And health has to compete with many other priorities within the country. And as you know, in the region, our country is one of those few countries that have raised our proportion of the health budget, proportion of the national budget that goes to health quite significantly. However, we still need to increase that to be able to reach our goals. Of course, again, as you understand, our counties have had initial challenges in rolling out some of these programs, but we are now farming up some of these things, and in many counties, we see a lot of significant progress, and we believe that we are looking up as a country in terms of healthcare.
You know, I'm pushing this agenda, Dr. I am thinking of the ICCM, the research, the findings, the program. Okay.
What is ICCM?
Yes, I'm going to go. Surely I have to sound a little complicated before I unwrap it. Yes. XYZ. Okay. Integrated Community Case Management. Okay. I know the research project was carried out in Homa Bay County. Okay. Now the focus was on 3 diseases: pneumonia, diarrhea, malaria, and it was to try and determine if these cases can be diagnosed and even treated at the community level before somebody even gets to a clinic. Right? Now, the findings, I'm summarizing the findings of a 3-year research program, and then 3 to 4, was that a program such as this one, where you train community members through the help of the community health workers to actually understand how to diagnose just pneumonia. I know it sounds a bit strange. Pneumonia, diarrhea, and malaria. What was found was that this simple process would actually prevent up to 75% of health care seeking within health facilities. Okay? But this was what was required. Now, why am I talking about saying this? I'm saying with healthcare, sometimes whatever processes we go through must be informed by research findings or by scientific findings. And this is something that has not only been found to be true, but it actually exists. Now, has the ministry considered applying the findings of, say, something like this research process into their outreach with community health workers and in the preventative aspects of healthcare that the ministry is focusing on?
Thank you, Siti. And this will be borne out by our curriculum for community health workers and volunteers. When you look at the content of their curriculum, it is based on the disease burden. And we have what we call lay case definitions for these common diseases that we train our community health volunteers to identify some of these priority diseases. And as you rightly say, those three diseases, diarrhea, pneumonia, and malaria, account for the largest burden of our diseases. However, they can also be controlled by the simplest of measures.
True.
Diarrhea, by just giving ORS, you're able to sort out, to prevent most diarrhea deaths. Pneumonias, by early diagnosis of pneumonia, which is simple. When you simply look at a child and they're having difficulty breathing, they are straining on breathing, you are able to administer simple medication like amoxil at home, and that will sort out most of these pneumonias. Of course, the other key area that sorts out the pneumonias is encouragement of vaccination. And then, of course, for malaria is bed net use. So these are areas that our community health workers are already trained on, and they can prevent most of our disease burden.
My final question wants to focus on financing. You've said, yes, Kenya is one of the countries in the region that has really upped the amount of national budget that goes to health. But also, Kenya is also one of the countries that has really benefited from external support in our healthcare, in HIV, in malaria, in TB, and others, right? And in fact, recently we were having a conversation on, now that the donors have said our program will be coming to an end and we'll start reducing the amount of money and support that we are giving you, then you should start taking that up. How is our disease surveillance and response anchored towards that? Have you been receiving a lot of external support? Are you prepared? Are there plans to start financing more and more own source revenues and own source financing of this?
Yeah, thank you. And to talk to that, of course, the ideal situation is that countries take full care of their healthcare. And there is a commitment on the African continent on what we call the Abuja Declaration, which expects countries to put aside 15% of their national budgets towards health. However, as you know, there are a lot of competing challenges nationally, and this is why sometimes these budgets are not attained. However, the beginning, as we said, is to first emphasize preventive healthcare. We reduce the burden of disease in the health facilities, then the demand on resources will also go down. The other issue is about reducing the burden of healthcare to the individual, because healthcare can be quite catastrophic to individuals. So the government program of universal health coverage seeks to reduce the financial burden to indigent populations by expanding, for example, the reach to insurance cover. As you have seen, this is a program that is ongoing. The government is trying to expand the reach of persons with insurance cover. Of course, we are also seeing an expansion of the county health budgets, because health is largely a devolved function now, and counties have been encouraged to expand their health budgets. If you look around, most of the counties, a significant portion of their budgets goes to health. So I think, again, this is work in progress, and we have, as we go forward, we have to learn to live within our means and to take care of our priorities. And I think this is ongoing.
Thank you very much. Dr. Emmanuel Okunga is the acting head in the Division of Disease Surveillance and Response at the Ministry of Health. We've been talking about very many issues on the health front, but most importantly, talking about the ongoing vaccination campaign against polio in 13 counties in northeastern, in parts of coast, in parts of lower eastern, and also in Nairobi and Kiambu. This started on the 17th of July. It concludes tomorrow, and in some counties, especially northeastern and in the coast, it continues until the 22nd. Daktari, asante sana for joining us.
Thank you very much, City, and kindly encourage our people in Nairobi to avail their children for vaccination, especially in the gated communities and the well-to-do segments of society. The fact that you are from the high end of society does not protect you from polio.
How old must the children be? What's the cutoff age?
5 years and
5
below.
years.
And below.
Asante sana.
Yes.
This is the Situation Room, the only way to start your day.